And so next up on Shark Tank, I have Jessica Farrell, Deepika Thacker, and Ariana Powers. They're going to talk about an innovation that I really would have loved to have had way back in 2003 when my son with HLHS was in the hospital the first time. And this presentation is on a structured approach to supervised family care prior to hospital discharge. So let's see what they have to say.
Hi, my name is Jessica Farrell. I'm a nurse on the cardiac step-down unit at Nemours AI DuPont Hospital for Children. Our project we did is a supervised family care. It is a quality improvement and project we wanted to work on. Next slide. So the objective of the supervised family care is to verify that the education provided to the caregivers of patients with a complex cardiac diagnosis has been effective. So we identify and correct any deficiencies in teaching prior to discharge and ensure a safe discharge. The standardization of the supervised family care is a quality improvement initiative, and it's led by myself, Dr. Thacker, and Ariana. The project has been going on and it's being reevaluated on a regular basis. We meet every so often to discuss. We have worked on a policy and procedure as well to achieve standardization of this project. Revisions have been made using feedback from families, nurses, and providers as well. So which patients qualify for an SFC? We decided that you have to meet one or more of the following criteria. Patients that require medical technology at home, including but not limited to tracheostomy, ventilators, gastrostomy tube, nasogastric tube, feeding pumps, apnea monitors, ostomy, or ventricular assist devices. Patients that have been admitted since birth and have had extended medical stay of 2 weeks or greater, or patients that will require 3 or more medications, which failure to administer those medications could end up in hospitalization. Any child protective services involvement, and patients requiring an injectable medication.
Hi, I'm Ariana Powers. I'm the clinical specialist in the cardiac center. So during some of our PDSA cycles, and as we are evaluating our quality improvement project, we have made some changes. So one of those is our SFC duration algorithm. So when we first started, we were requiring everybody to do a 24-hour SFC. And then we realized that there is a population of our patients that probably only need 12 hours instead of 24. So we have an algorithm that tells us the length of how long we would want the family to practice their regimen at home. So trach vent dependent patients will always be at 24. Caregivers that are unable to spend significant amount of time at the bedside, caregivers that have been inconsistent active participants, and often that can mean that they're nervous. Patients that have had all the education completed or that social work has concerns, or a patient with complex medical needs. But then we have found that some of our patients and their families who have been able to participate in their care more and completed all of their education in a timelier fashion are able to just do a 12-hour practice during an SFC. And what happens during SFC? So what we tried to do is emulate the home environment as best as possible. So the caregiver assumes the care of the patient for the duration of the SFC. We try to turn off the monitor in the room so that they're not staring at that because they won't have that at home. They measure medications and administer all the medications as best as we can do in the hospital. We still have to administer the medications that come from pharmacy, but we have a way for them to measure what they would be doing at home. They will do all the feedings, all of the activities of daily living, such as bathing, changing diapers, all that kind of stuff, and the use of any applicable technology for that particular patient. And what happens during the SFC, regardless of the time frame, is that sometimes we find out that there's something the caregiver didn't really understand and needs reinforcement. So what happens when we assess that is that We do education as needed, and we meet with social work, nursing, and the medical team to evaluate any further needs and come up with a plan for a safe discharge. So we are gathering data for this project, and currently we have surveys that are given to nurses and families. Social work will follow up with any families individually when necessary, and the SFC team follows up with any nurses and their feedback as necessary. We use all of the feedback to improve our process, and we continue to do this because the literature review prior to the start of this QI project did not yield any information related to SFC in the congenital heart defect population. So we're hoping to be innovative here.
Hi, so I'm Deepika Thacker. I'm one of the pediatric cardiologists at the Nemours Cardiac Center and the director of the inpatient medical unit. And we are very excited to bring this project to you. Why we think this is innovative is, like Ariana and Jessica already said, very little has been written about the process of the SFC process or a similar process other than a few short outlines and small case series. There was an article in the Journal of Pediatric Nursing in 1986, which talked about a similar process for discharge preparation for caregivers in only 6 ventilator-assisted children. We've completed about 65 so far since October 2019. And those are the ones that we've documented formally. So we started the process a little bit before that, but again, more formally since October 2019. And just looking at the raw data, I would say we've identified deficiencies in at least about 30% of those, and we're still analyzing the data in an ongoing manner. Next slide, please. So in the words of Dr. Tony Sesta, as written in Case Management Insider, we place great responsibility on individuals while their loved one is in the hospital. We don't always prepare them as adequately as we should for the tremendous responsibilities they will be assuming. Family caregivers may be shown the equipment or procedure while the patient is in the hospital, but in the home environment, they may forget what they've learned. And so through this process, we're trying to simulate their home environment to make them comfortable when they go home. Data obtained through a closed online discussion group via the main Facebook page of the Children's Heart Federation, a national charity offering support to children with heart disease and their families in the UK. This was what was expressed in that data. So parents expressed various difficulties and a sense of isolation in caring for their child after discharge. They also, however, reported positive experiences focusing on the pre-discharge teaching and supervised training to care for their child. And so we took some of that data and we really want to try and incorporate that into our teaching for the families. Next slide, please. Why this is important? It's important to allow a child's caregiver to practice the skills that they have learned, to feel confident in their abilities to care for their child independently at home, to provide reinforcement in teaching where needed, and to ensure a safe discharge for our little one with a heart problem and complex medical needs. And so, like Ariana mentioned earlier, we are taking some of that data in an ongoing manner and analyzing the feedback and striving to continuously improve this process. One of the things we realized was that we were not having our families mix the formula because it was coming ready to us from nutrition, and we are now going to try and incorporate that into the SFC process as well. Next slide, please. And so this is what our families have to say about this. Like I said, we have family surveys that we have them complete at the end. And a large majority of the families find that this process is extremely helpful in making them feel more comfortable with the discharge of their child. And so next slide, please. This is our team. And as you see, it's not a one-person team. It's a big team, very closely involved and continuously working to make this as easy as possible for our families. And our patients and their families are the most important part of our team. So thank you for allowing us to be a part of your care.
Hi,
So again, we have just an amazing presentation on innovative things that we are doing to make sure parents are prepared when they go home with their child from the hospital. And so we would love to open it up, Andrea, to questions and see if you all have some questions to answer.
Yeah, so I have a few questions that have come in. One, which is a great one, is what barriers exist for parents to benefit from this process, such as language barriers, cultural barriers, and then what are the efforts that you're taking to reduce those barriers?
So I can answer that. I think some of the barriers, like you identified, one is parent availability. You know, they have jobs and other children and other responsibilities outside of the care for the child in the hospital. So scheduling a time, and then transportation issues. So even the process of setting them up to come in for an SFC sometimes can be challenging. Two is in some situations like a tracheostomy, the availability of a second caregiver is required, and that can be challenging. And then definitely language, as you mentioned. So we have on our team, social work helps us with some of the initial difficulties we talked about. And then we do have education materials and then excellent in-person services for interpretation that we utilize to overcome some of these barriers. Ariana and Jessica, I don't know if you want to add something to that.
I think that our social work team is extremely helpful in that. They coordinate with the families early, and I think the families know what to expect, and they are proactively telling us when they could do it. So I think that helps. We do have some materials in Spanish, and we will work hard with any team to try to make it accessible to all of our patients.
Yeah, great, thank you. So once the child is back home with the family and say a few weeks go by, does the family have an opportunity to get back in touch with the same team for continued support?
Jessica, do you want to answer that? We just talked about that, so go ahead.
Yes, so we had just discussed how the proper way to follow up to make sure that these parents have continued support from the team. So we had talked about re-administering the survey on their post-operative visits or the first visit with their cardiologist. So hopefully to get them within 30 days. They also are discharged with a phone number, so they can always call us, and we are keeping track of the parents who call of children with SFCs and documenting those.
Great. And the final question is, are there resources available if the parent comes home and later becomes uncomfortable with the care that they need to provide their heart child?
Ariana, do you want to take that?
I think we do. Sure, I can do my best. Jess might have some more information, but I think that we send them home with the most amount of information, and especially written information, so that they can look back. They do have access to us 24/7 if they do have questions that we could answer over the phone. We would have to sort of log into the chart and look and double check things, so it takes a little bit longer. But we try to make sure that they are as best prepared when they leave, and that they could look at those resources again. We also have a discharge coordinator that will provide them with all the supplies that they need and all that information too. So we think they're well prepared to sort of answer their own questions when they're at home, but we're also available for them.
Yes, I agree. This process is all new, so it is continuously improving. We have found that we really haven't had a ton of follow-up, say weeks and weeks past discharge of patients that have had SFCs of their parents calling. So it seems as though they've gotten the amount of resources they need at discharge. We haven't had a lot of parents reach out about it yet.
We do
Which is
make a discharge phone call as well to make sure they're comfortable. And just that's like 24 hours or 24 to 48 hours after discharge, right?
Yes, we have 48 hours to complete the discharge phone call.
Great, great. Okay. I think we are at time duty, and we will, one quick question, SFC, what does that stand for again, for anybody who might be a little confused?
It stands for Supervised Family Care.
Perfect, thank you.
So Deepika, Ariana, and Jessica, you guys are amazing. Thank you so much for being here today. We can't even tell you how much we appreciate you and all of you at Nemours, Alfred I. DuPont Hospital for Children. It's just really wonderful to hear about all of the innovative things you are doing. And stay tuned, because after this day of Shark Tank, we're going to have another innovation from them coming to you.
Thank you so much.
Thank you so much.